PMS on steroids, PMDD, premenstrual dysphoric disorder. Does it exist? What is it? What can you do about it? We're going to give you an ABC 1, 2, 3 step approach to how you can handle PMDD. If you're battling issues, you women, hormonal imbalances, this will be a great subject, a focused approach to help you. Welcome to another edition of our live streams. Thrilled that you're with us. Today's subject, one we've already done, updated version. PMDD, premenstrual dysphoric disorder. PMS on steroids. It's about the only way that I could describe it. It's about the only way that I could kind of bring it to you. So what are we going to cover today? ABCs, a quick overview. Thousands, millions of women suffering, literally, with severe PMS, one thing. So this is kind of an overlay of PMS that goes to the next level with premenstrual dysphoric disorder. So what is it? We'll define that. It is, in essence, a PMS woman on steroids. Big time, heavy duty, premenstrual dysfunction, and it leads to mood disorders, depression, anxiety. It disrupts a home, a family, let alone the individual's life. So let's just get right to it. We're going to keep these concise and very, very tight. So as I headed, PMS on steroids, PMDD. So what is it? How's it characterized? In the luteal phase, the second part of your cycle, a woman's cycle, there are huge issues with breast tenderness, mood disorders, anxiety, almost to the point of depression and severe anxiety, lower abdominal pain, low back pain, possibly disrupted or heavy cycles. That's not really the issue what I want to focus on today. I don't want to focus on heavy cycles, menorrhagia, so on. This is about very severe dysfunction in that luteal phase from the time of ovulation until a woman's cycle begins, her period begins. So what are the typical medical treatments? The typical medical treatments, by the way, if you're new to us, who am I, what am I? If you've just tuned in, maybe someone referred you to this video, Joe DiMatteo. I'm a pharmacist, I'm a naturopath, I'm a clinical nutritionist, and also a homeopath. We do a national radio broadcast. We do local broadcasting. If you've just found us on YouTube, go to AskJoeDiMatteo.com. Should have headed the beginning of that with that, but it doesn't matter when we do it. PMDD. Women are, in many cases, so severely disrupted they can't get through their days. It leads to severe, in some cases, depression. Back to what the medical treatments are. Sometimes antidepressants. They'll put women on antidepressants. Effexors, Prozacs, selective serotonin reuptake inhibitors. Point number 2, the medical treatment is to use drospirenone, a synthetic progesterone, progestin. If that's not effective, they'll add a synthetic estrogen to that. By accounts, I did the research, the literature reviews, they feel that they are mildly beneficial, the synthetic hormones at best, and most of the effect is more of a placebo effect. Some women garner effect or benefit from the selective serotonin reuptake inhibitors, the antidepressants. But my point is it really a matter of depression, or is it an issue with hormones, et cetera, et cetera? So let's continue to move on. If you have been through this route and you have used medications and you have had nothing but side effects, which is usually what you'll have with the synthetic estrogen, synthetic progestin compounds, sometimes headaches, more bloating, more mood disorder, maybe your PMDD symptoms quiet down to some degree, but we want to get you to a functional state. Do we know exactly what this is? No. Does medicine know exactly what triggers this? I'll give you some theories, some themes. Number 1, women that usually are heavy PMS'd, to the point of PMDD, usually eat too many carbs, too much sugar. Some of the literature shows that women in this category can increase their intake of sugar in the later part of their cycle by 300%. Carbs by well over 200% of what they normally consume. Sodium intake usually increases. So there's significant food intake disruptions. Carbs are usually craved intensely. Too much caffeine is a trigger for PMDD. Ethanol, alcohol intake is also a trigger for this as well. Hormone imbalances, estrogen to progesterone imbalance in ratios. I believe this is at the core of this. Lastly, liver detoxification. Poor liver excretion, liver detox pathways are congested. Many women are constipated, don't have good bowel movements, have a liver that's overloaded because of what we're all exposed to, chemicals, colors, dyes, that begin to overload the liver. The liver's congested, you can't process well. Nutrient deficits are at the hub of this as well. We often see women with PMDD have significant nutrient deficits, specifically the Bs, the family of Bs. More specifically, B6. But many women try B6. Doesn't always work. Why? It's straight pyridoxine hydrochloride. In our coenzyme B complete, which we'll talk about a little bit later, we use the pyridoxal 5-phosphate form. What that means is that's a body-ready form. Your body it's already converted so that your body does not have to. So let's go back. What's the cause? Well, the prolactin issues, estrogen dominance. No one really knows. I don't know that there's one singular factor. I don't know that there's just one. I believe what we have is a combination of components, and they could be nutrient deficits, they could be estrogen dominance, they could be progesterone deficiencies, liver congestion, prolactin levels that are elevated, and they're not solved by just a selective serotonin reuptake inhibitor, an antidepressant. They're not just solved with a synthetic progestin or progestin plus synthetic estrogen combination. I don't believe that's what it is. And I believe that why most women do not succeed in this area is because they don't do it as a protocol. So that's what you have to see. I think in order to garner success in this area, you have to be able to engage in a protocol, a comprehensive approach. PMDD, PMS on steroids requires heavy-duty approaches that are consistent and that are not singular. I wish it was as simple as go take this, B6. So often I hear from women, well, I tried B6. I said, well, first of all, what was your form? But you can't just use B6. You got to use the B complex. Well, I tried magnesium. I heard magnesium was an issue. What's your form? But you could use magnesium and get 20% benefit, but you could have some other issues. You could have liver congestion. You could have elevated prolactin, which zinc could help you with. You could have imbalances of estrogen to progesterone. My point is, you can't look at this as a singular nutrient and approach and then expect to have the benefits 100% or even 70% or 80%. I believe that's where we come back to the protocol. Zinc deficiencies will allow for prolactin levels to elevate. That usually plays a very, very key role. Now today, Josiah is going to help me keep time. We're going to try to keep this to about 15 minutes or so. We want to keep this tight, clean, so that you can apply. And I want you to be able to relate this to friends, to maybe other women that might be battling this. Vitamin D and omega-3 fatty acid deficiencies are also implicated. But your core big players are imbalances in hormone. That's why you see the majority of the problem occur in this with PMDD, premenstrual dysphoric disorder. Day 1 is the first day of your period. Day 14 is the midpoint of your cycle. Hopefully day 28 or day 30, the end of your cycle and the beginning of your period. The majority of PMS, PMDD issues occur here in this luteal phase, the final 14 days. My opinion is that if a physician feels that it's a depressive disorder or an anxiety disorder, and often you're put on Ativan or Xanax and a Prozac type medication, if that were the case, if that were necessary, not in my opinion, but if it were necessary, would it not be that you would suffer this the entire month? 28 days, 30 days. Why is it that we have the preponderance of this occurring in the latter part of this cycle, and then you have relief typically early on? If that's not you, then you need to go see a psychiatrist. You need to see a physician that would work with you to try to balance your neurotransmitters or do medications or whatever. But if you have significant issues, this conversation's for you. If your issues are in this area, day 12, 13, 15, 17, through day 27, through day 28, 29, then this is appropriate for you. What's the approach? What do we do? How do we help you? That certainly becomes really the $64 question here, and that's really the key, and that's really where we want to go. But you need to understand some of the background, I believe, before we can actually help you. So what's the approach? Number one, it starts with your diet. Moving to more of a plant-based diet, high in fiber. That doesn't mean you don't have protein, God forbid. That doesn't mean you can't have animal protein wherever you are in that scenario. That's not what I'm here to try to teach in this protocol. This is about plant-based foods, more fiber, less bad fats, less sugar, and at all costs, you must do this. You've got to maintain the dietary component. It starts with your diet. Number two, it will start or be supported by exercise. You must move. Literature shows that women with severe PMS to PMDD are typically in this phase of their cycle more sedentary, do not want to exercise, do not want to move, eat more junk foods, are in front of the TV for longer periods of time, very dysfunctional, very emotionally distraught. We need to change this cycle. And I can't just tell you don't sit in front of the TV. I've got to get you feeling better, but I got to get you out walking and moving. Diet first, plant-based, plenty of vegetables, plenty of fruit, lean proteins, reduce your white flours, your sugars, your saturated, deep-fried types of fats. Movement, it's important. It balances your hormones, stimulates your detoxification. Nutrient deficits, big problem here. You've got to use, or you have to replete with, we use a product called Coenzyme B Complete, because it's a complete B. It is in the coenzyme form, and it has the methylated form, quatropolic, the methylated form of folic acid that really enhances its uptake and utilization at a